Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy life. I'm Pat Anderson, editor of MIMS Learning. Late last year, we ran the MIMS Learning Live North event in Liverpool. This is a one-day event that we hold every year, and it provides a packed day of clinical learning across 2 streams, featuring multiple topics in each stream. The idea is to update GPs on just some of the range of presentations and conditions that they might see in their clinical work. Bearing in mind that earlier cancer diagnosis is a priority for the NHS, we asked haemato-oncologist Dr Majid Kazmi to come and talk to GPs about diagnosis of haematological cancers. This is a complicated area, by the sounds of it, and GPs need to be aware of what test results could mean and when urgent referral may be required. So while I was at the event, I took the opportunity to speak to Dr Kazmi before his talk about diagnosis of haematological cancers. So I'm delighted to have with me today Dr Majid Kazmi, who's a consultant haematologist, if that's correct. And we're going to talk today about the role that GPs can play in the earlier detection of harmful haematological cancers. So first of all, could you perhaps tell us a little bit about your current role?
Yeah, sure. So I'm Dr Kazmi. I'm a haemato-oncologist because I specialise in blood cancers. And I've been practicing as a consultant in London at Guy's and St Thomas's Hospital since 2000. So many years of experience, had a variety of other roles, including Chief of Cancer Services. So I was responsible for all cancer services, not just blood cancers. And so I've been intimately involved in how we improve the diagnostics and the pathways for patients with potential cancer diagnoses.
Brilliant, thank you. So first of all, could you give us a sort of brief outline of how common haematological malignancy is and the impact that it can have on patients' lives?
So one of the challenges around haematological malignancies is there's not just one group.
Right.
It's actually quite a diverse group of diseases. But when you group them all together, actually it's the 4th most common cancer that we see. But each individual subtype may actually be quite rare, but it's actually the aggregate that makes it the 4th most common. And unfortunately, one of the challenges about haematological cancers is the symptoms can often be very vague and quite difficult to spot. So there are certain things you need to be aware of and to look into, which we can perhaps go into.
Sure. And as regards the impact on patients, presumably these can have very profound impacts on patients' lives.
So again, given the heterogeneity of the different types of cancers we see in haematological cancers, you can have certain cancers that can be immediately life-threatening. So that can actually, within a few weeks, a patient can pass away because of the aggressiveness of the disease, all the way to the other spectrum, where it can be very indolent and people can live quite happily, even without any treatment, just being observed for decades. So that's, again, presents a real challenge about a pathway that's designed for a solid tumour may not be the ideal pathway for a haematological cancer, because you could end up either being too slow in seeing some patients or actually scare other patients because you're seeing them too quickly and they don't really need to be seen that urgently.
Yeah, that's really interesting to hear about the sheer range there. So if I was GP, what should I have on my radar when I see a patient in front of me?
So first thing I would say is that haematological cancers, like all other types of cancers, are increasingly common as you get older. So in a young person, although we hear a lot about sort of blood cancers in young persons, like lymphoma, etc., it's actually quite rare. It's about 1 in 100,000 or less.
Right.
But as you get older, the risk of developing a blood cancer of some description increases with age. And so that's the first thing. Is this patient in the age group that would normally be considered the risk age group for a blood cancer? Then the symptoms, as I said already, can be very vague. Fatigue, non-specifically feeling unwell, maybe getting weight loss, maybe getting some night sweats, maybe getting some easy bruising. There can be a whole load of vague symptoms. In some cases, it can be swollen glands. In other cases, it can be pain in the bones, and usually in the back.
Okay.
But again, as you can imagine, as a primary care physician, those are very common symptoms. People feel tired, people feel not well, maybe have lost a bit of weight, maybe get an odd back pain. So that's the real challenge with hematological cancers. How do you separate what's a real red flag symptom from what could be just musculoskeletal pain just because of exercise or aggravation because of work?
Yes, so that must be a real challenge for GPs. So are there other factors around that might perhaps prompt a GP to consider haematological cancer? Say, for example, if a patient keeps coming back, or some other pattern of consultation?
Yeah, I think that's the key thing. So I particularly specialise in a blood cancer called myeloma, and myeloma, probably out of all the blood cancers, is the one that's often diagnosed quite late.
Right.
And quite often it's when you look back, and we've done this analysis, you look back and see how many times that patient visited a primary care physician before they were finally referred in. It's usually 4 to 6 times.
Yeah.
With the same symptom. So I think for me, the warning things would be, somebody's never had back pain, is suddenly complaining of back pain, is over the age of 40, and there's no obvious reason why they should have back pain. That would be a warning for me to maybe think a bit harder about something else going on. Or if somebody keeps coming back and the pain hasn't resolved, hasn't gone away after 2-3 weeks, which normally would happen with a muscular type pain, it would get better. But if it hasn't, then again, that would be a kind of a flag to me that maybe I should do some more investigations. And what I'm really talking about at that point is either some blood work or some imaging.
Okay. Yes, so I was going to ask, what kind of tests and investigations would you expect to have been done by the time you see somebody?
A lot of hematological cancers, you may not pick up anything in the blood, but things like myeloma, you almost certainly will see some signs in the blood. And it's just a simple blood test, which what you'd look for would be whether the patient's a little bit anemic, whether the patient's got a raised total protein level in their blood. If you do a liver function test, and you might get a reading on globulin levels, if the globulin level is elevated. Those will all be kind of signs, or if the ESR is significantly elevated, those may all be signs there's something going on, in which case you might want to do further, more deeper tests or discuss it with your local hospital.
And once you get into the pathways and the referrals, what are the challenges that people are facing around those at the moment?
So once patients are referred in, then there's still in some parts of the country diagnostic delays, particularly around imaging and particularly around things like the latest technology in imaging, which would include either a PET CT scan or an MRI scan. There's significant diagnostic waits, unfortunately, and that's a real challenge. But I think for most hematological cancers, and lymphoma is the one I'll just put to one side for a second, but for most hematological cancers, the diagnosis can be made relatively quickly.
Right.
Because you can either pick it up in the blood or you'll pick it up on some imaging. The challenge with lymphoma can sometimes be it can present anywhere in the body. And so quite often what happens is the patient may be referred on the wrong pathway.
Right.
So they may have abdominal symptoms, may go into a GI pathway. There may be something seen on the scan. They think this maybe is colorectal malignancy, and then they'll go down that investigation. Then they'll find out right at the end it's a lymphoma. Then it has to be referred to the hematologist. So that can be a challenge with lymphoma, and sometimes just accessing the right area to biopsy with interventional radiology can sometimes be a challenge. So lymphoma is one of those conditions where it can present anywhere. We've often seen cases being referred to us from other cancer pathways because once they got right to the end of the diagnostics, they found out it wasn't what they thought it was, like a breast cancer or a lung cancer. It turned out to be a lymphoma.
Okay. So that obviously creates a delay for the patient. And I don't really know how these things work, but if somebody's in the system and they've seen the specialist about, say, for example, colorectal cancer pathway and been found not to be appropriate for that pathway, do you then have to kind of start all over again?
No, we certainly don't. We certainly don't send them back to the primary care physician. What happens is there's a inter-pathway transfer. So basically, we would be asked to take over that patient directly, and we would finish off whatever investigations were needed, and then do the appropriate treatment. So yeah, we certainly don't start all over again. And I think it's important to, again, for a lot of patients get worried about staging of their cancer, and they wonder how advanced is their cancer. That's one very common question. And it's quite important to recognize that for most blood cancers, we don't use as traditional staging systems.
Oh, right. Okay.
So people say, well, where's it spread? For most cancers, blood cancers, because blood goes everywhere in the body, it's often already in multiple places.
Right.
And that doesn't really matter. What really matters is how the treatment is going to impact on the disease and what's the response rate. The only sort of caveat to that would be specific types of lymphoma, if they're very localized, what we call stage 1, in other words, just in one area, potentially for some of those you can just get away with radiotherapy and not need any systemic therapy.
Right.
But that's a pretty unusual situation. For most blood cancers, we already know it's going to be in multiple places because blood gets everywhere, and we treat it with systemic therapy.
Right, right. So do you use a kind of different classification system, or is it kind of a specific one that's developed for this type of malignancy?
We don't use a TNM, which is a kind of classic staging system, which is the size of the tumour, any nodes local to the tumour, and any metastases. Mm-hmm. So that's a standard staging system that would be used for breast cancer or lung cancer. We have our own unique staging systems, depending on what kind of blood cancer it is. So for myeloma, it's really based on the cell proliferation. So how aggressive are the myeloma cells dividing? Okay. That defines the staging system in stage 1 to stage 3. In lymphoma, we use what they call a modified Ann Arbor staging system, which is basically which groups of lymph nodes are affected. Is it just one group? Is it more than one group on the same side of the diaphragm? Or is it across the diaphragm? Or is it beyond the lymph node group, which will be stage 4? Okay. And then there are other more rarer kind of blood cancers which have their own unique staging system. But for hematology, we have an advantage in that because for most hematological cancers, we've been able to get a lot of the tumor cells and analyze them. We understand a lot more about the biology of those tumor cells. And so our staging systems take into account not just how big the lump is or where it is, but also how aggressive it's dividing.
Right.
And whether within the tumor cells there's specific changes, what we call genetic mutations, that make that disease either more likely or less likely to respond to treatment.
Right.
So we have all of that information. We build that into our staging systems.
Yeah. Oh, that's really interesting. And in terms of, obviously GPs wouldn't be involved in the treatment side, but it might be advantageous for them to know a bit about it so as to advise patients. So are most patients that you see looking at having chemotherapy, immunotherapy, radiotherapy, I don't know, possibly surgery, or is there a kind of type of treatment that tends to be more favoured for this area?
For hematological cancers, surgery is probably the least used option. Mm-hmm. We very rarely, unless they've gone on for example, they were on the colorectal pathway, they actually had the surgery,
right,
and then they realized it was a lymphoma, not a colorectal tumor. So it's very rare for us to do a surgical procedure for hematological cancers. Depending on what type of cancer we're talking about in hematological malignancies, it can either be very aggressive inpatient-based therapy, so intensive chemotherapy for an acute leukemia, for example, and that's all done as an inpatient with a little bit of ambulatory care for subsequent cycles. But the first 1 or 2 cycles will almost always be done as an inpatient. Other more indolent hematological cancers can often be treated as an outpatient. Again, we've been very fortunate in that we've led the way in developing targeted therapies and immune therapies. So there's been a paradigm shift, if you like, over the last 20 years, moving away from traditional chemotherapy, which is the kind of thing that makes your hair fall out, makes you very sick and all of that, much more towards what we call novel therapies, no longer novel, better to call them targeted therapies, because they specifically target a pathway. So, for example, the first drug was a drug that was defined for a condition called chronic myeloid leukemia.
Right.
Now, when I was training, chronic myeloid leukemia had a life expectancy of 3 years, 4 years. And unless you had a bone marrow transplant from a donor, you were unlikely to survive. But we always knew, and we knew for a long time, that it was driven by a particular change, what we call a genetic mutation in the cell called a Philadelphia chromosome.
Right.
So basically, genetic material went from one chromosome to another, and that made that cell divide in an uncontrolled manner. And what happened was, because we knew that, people were able to define a target that stopped that happening. It didn't stop the translocation happening, but it stopped the effects of the production of the protein that came from that. And that was the first targeted therapy. And what it really did was just a tablet. It basically transformed the treatment of chronic myeloid leukemia to now where it's almost a curable disease. People are just taking a tablet and they're living 10, 20, 30 years. And that's just happened in the last 20 years.
That's amazing. Amazing. Yeah. So transformed landscape. So do GPs perhaps need to be aware of how things have changed in this area?
It's difficult, but I think the real message for primary care is you will come across more and more of these patients because they're living longer.
Yeah.
So they will come back to your practice. May not be directly related to the treatment that we're giving, but for example, these drugs I just talked to you about, which help in chronic myeloid leukemia, have cardiotoxicity.
Right.
So, for example, they may come to you with feeling shortness of breath or other things. So it's important that you're aware of some of these therapies and what some of the side effects are, and that you have a liaison with your local haematology department so you can ask for advice if a patient does present. I mean, to be fair, we as haematologists tend to hang on to our patients.
Right.
We very rarely discharge them.
Okay.
So it's usually we're still seeing them. We're well aware of these issues. But it is important that primary care physicians support their patients because they're living 10, 20 years now with their diseases, and more and more of them. So again, in my area, like myeloma, when I started, median survival 2 to 3 years. It's now over 10 years.
Yeah, it's quite astounding, really. So if a GP knows that the patient has a past history of cancer, presumably that's something that would make your alarm bells go off more readily if they come back with suspicious symptoms. And also, would it change the way that you manage other risk factors in that patient, such as cardiovascular risk factors or other comorbidities? Would it have an impact on, say, for example, how you manage their diabetes?
I think that's an interesting question because there's two things that we're finding now, which is a challenge for all of us, which is one is because people are living longer, if they've had one cancer diagnosis, they're more likely to get another one at some point in time. It can be the same cancer coming back, which is recurrence, but quite often now, for example, if you've had treatment for breast cancer and you successfully treated for that, statistically, there's a higher chance later on in life that you could develop a blood cancer.
Right.
Because of the chemotherapy and the effects of that treatment. So these are things that we're now picking up as hematologists. We're seeing patients who are coming through who successfully were treated for a different type of cancer, but because those treatments in those days were chemotherapy, they affect the way cells behave, they can potentially increase the risk later on in life of developing a blood cancer. That's a real challenge for us, and we're seeing a lot of that. But the other thing we're seeing is because people are living longer, they have multiple comorbidities.
Yeah.
And so we can't just, as hematologists, just treat the disease. We have to also look at the holistic needs of the patient, and that may be things like diabetes, high blood pressure, kidney dysfunction, heart dysfunction. And so, yes, we work very closely with our general medical colleagues, with our primary care colleagues, just to make sure we've got that full holistic package around the patients rather than just focusing on the hematological cancer.
Yeah. Is there anything that you wish GPs knew about this area that would help patients that you see?
I think one of the challenges for all of us has been, as everyone's got so busy, that kind of close liaison that used to happen a lot with primary care in the local hospital, that's kind of not so easy there. And what I think really is helpful in this context is just getting on the phone and speaking to your hematologist and just asking them, is this something I should be worried about or not? Now, I know we've got advice and guidance systems all set up in place, and they tend to be a little bit impersonal, but it works. But I think that will be the key thing for me, because as I said earlier, you could have a patient who's clearly got a form of chronic leukemia, but that is something that is not going to need treatment, maybe never need treatment. But you send that patient on a 2-week wait cancer pathway and you're scaring that patient, making them worried. Whereas if you got on the phone and spoke to the hematologist and said, how urgent is this? Do I really need to send this patient in now? You could avoid a lot of anxiety. I see a lot of patients coming to my clinic so scared, so terrified because they think they're going to die because the GP told them they've got some form of chronic leukemia because that's what it came on the report from the lab. but gave no other context.
Right.
And so when they come and see me, they're really terrified. And I have to spend the first 15 minutes calming them down and trying to just explain to them that just because it's a leukemia just means too many white cells in the blood. That's all it means.
Oh, okay.
Because you got that connotations of the word leukemia means everybody thinks that's it.
Yes.
You know,
yeah.
I need to write my will and everything. It's not like that for a lot of them. So you have to just give that context. Whereas if the GP had got on the phone and said, got someone who's got a report of chronic lymphocytic leukemia, white count is only 10, do I need to be worried? And I'd advise them as to whether there are other warning things to look out for.
Yeah.
So I think that's the main thing, because these hematological cancers are quite tricky. There's no way you can write a guideline that would cover every scenario, and we've tried,
Right.
but you can't. In some ways, it's just better just to speak to the local hematologist, get some advice, and that way you're more likely not to miss something when it needs to be seen urgently, and not to scare somebody when it doesn't quite need to be seen so urgently.
Yeah. Sounds like the way to go. So a little bit of a personal connection and picking up the phone might have a lot of benefit. Great. Well, thank you so much for talking to us today. Really appreciate it. And you're speaking to GPs today about diagnosis of haematological cancers at MIMS Learning Live in Liverpool, and hope that goes really well, and we'll look forward to seeing you at future events perhaps.
Thank you very much.
Thank you.
It's a pleasure.
Thank you. So that was our interview for this episode. Dr Kazmi's talk went down really well and featured interesting case studies with participation from our audience of GPs. So we hope to see him again in this capacity. Thanks very much for listening to this podcast, which forms part of our Patient Presentation Pathway for Cancer campaign around earlier diagnosis. This campaign aims to help GPs control what they can control around earlier diagnosis, providing tips to help you keep cancer at front of mind and make best use of referral pathways. Don't forget you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate and find links to useful resources and further reading. You can also find lots more free resources around earlier cancer diagnosis. I'm Pat Anderson, and this episode was produced by Till Owen. Don't miss next week's episode, and we'll see you then.